Okay, let's dive right into this explainer. Today, we're taking a journey from a common, tiny, often ignored organ all the way out to the massive, complex neighborhood that surrounds it. We're talking, of course, about the appendix and the peritoneum. Now, whether you're actively grinding through your medical licensing exams or you're just genuinely fascinated by the incredible interconnected mechanics of the human body, you're going to want to pay attention because this is incredibly high-yield stuff. We're taking a really deep look at how one tiny, seemingly harmless obstruction can cascade into an absolutely massive abdominal emergency. Right off the bat, I want you to just process this number. 250,000 cases. That's 250,000 cases of acute appendicitis reported every single year in the United States alone. To put that into perspective, this condition strikes about 7% of the entire U.S. population over their lifetime. It usually hits patients right in their 20s and 30s with just a slightly higher male-to-female ratio. Honestly, if you're planning to work in an emergency room or really any clinical setting, you are going to see this all the time. It's an absolute staple of emergency medicine. So here is our roadmap for today. We'll be covering 1, the classic medical emergency; 2, pathogenesis and complications; 3, rare tumors of the appendix; 4, the jelly belly phenomenon; 5, inflammation of the peritoneum; and finally 6, peritoneal tumors and fibrosis. Part 1. The classic medical emergency. Let's look at Calvin Garrett's case. So let's take a textbook clinical vignette. We have a 24-year-old guy named Calvin Garrett. He starts experiencing this vague, kind of dull periumbilical pain right around the belly button. Then, over several hours, that pain slowly migrates down to his lower right side. Now, this migration is a classic clinical hallmark, and we see it in about 50 to 60% of patients. Why does it happen? Well, initially, the inflamed appendix stimulates visceral afferent pain fibers that enter the spinal cord at T8 to T10, and that's what causes that vague central pain. But as the inflammation literally burns through the appendix wall and irritates the overlying parietal peritoneum, the pain sharply localizes to the right lower quadrant. To diagnose this, we use a specific set of physical maneuvers that map perfectly onto the anatomy. And listen up, because these are major USMLE buzz points. First, we have McBurney point tenderness, which is located exactly 2/3 of the distance from the umbilicus to the anterior superior iliac spine. Then we have the Rovsing sign. This is wild. Pressing on the left lower quadrant paradoxically causes pain in the right. We also have the obturator sign, where internally rotating a flexed hip triggers pain. And finally, the psoas sign, where passive hip extension causes pain, which tells us that the inflamed appendix is laying right on top of that psoas muscle. Moving on to Section 2, pathogenesis and complications. You really have to think of the appendix like a tightly sealed pressure cooker. Step 1 is almost always a luminal obstruction. In kids, this is often due to lymphoid hyperplasia from a recent viral infection, whereas in adults, it's typically a hard little stone of feces called a fecalith. Once that tube is blocked, the appendix just keeps secreting mucus, triggering a totally catastrophic cascade. Intraluminal pressure absolutely skyrockets to about 50 to 65 millimeters of mercury. This intense pressure physically collapses the venous drainage, so blood can't get out, but the arterial blood keeps pumping in. This causes severe congestion and mucosal ischemia. As the tissue gets starved of oxygen and dies, it ulcerates, throwing the doors wide open for intestinal bacteria like E. coli and Bacteroides fragilis to invade. This drives a massive, angry transmural inflammation that burns right through the wall, eventually leading to a full-blown perforation. Seeing this visually really drives the point home. If you look at a normal appendix, it's smooth, slender, totally unbothered. But compare that to an acute phlegmonous appendix. It is severely swollen, super tense, and you can clearly see these heavily congested, angry blood vessels tracking right along the serosa. If you were to look at this under a microscope, you'd see that the entire wall is being absolutely swarmed by a dense army of neutrophils. And here's the dangerous part. If that pressure isn't relieved by a surgeon quickly, this organ will undergo hemorrhagic infarction, turn pitch black, and rupture. That spills highly infectious, toxic contents straight into the normally sterile abdominal cavity. All right, Section 3, rare tumors of the appendix. So beyond just inflammation, we have to distinguish between the two main types of appendiceal tumors. On one hand, we have neuroendocrine tumors. These are the most common, making up about 80% of all appendiceal neoplasms, and they usually behave benignly. Here is a massive high-yield board fact for you. These neuroendocrine tumors will stain positively for chromogranin A and synaptophysin. Definitely commit those to memory. On the other hand, we have the much rarer epithelial tumors, specifically mucinous neoplasms. These are entirely different beasts, and they can lead to some incredibly aggressive, life-altering complications. Now, this is exactly what one of those neuroendocrine tumors looks like in real life. They are usually found completely by accident, just incidentally during a routine appendectomy. You can clearly see this very distinct, well-circumscribed yellow nodule sitting right down at the tip of the appendix. And because it's way down at the tip, it rarely causes an obstruction. Also, it's really worth noting for your exams, while neuroendocrine tumors in other parts of the gut might metastasize to the liver and cause classic carcinoid syndrome, that scenario is exceedingly rare for primary appendiceal tumors. But let's switch gears and talk about those concerning mucinous epithelial tumors. With these, a single genetic glitch can drive absolute catastrophic growth. We frequently see activating mutations in the GNAS gene and, vitally, the KRAS gene. A KRAS gain-of-function mutation basically causes the cellular signaling pathway, specifically the MAKK pathway, to get permanently stuck in the on position. It's like a gas pedal pressed all the way to the floor. This drives unchecked continuous cellular proliferation without the cell needing any external growth signals whatsoever. Which brings us to Section 4, the jelly belly phenomenon, or pseudomyxoma peritoneia. You know, pathology is full of surprises, but this condition, pseudomyxoma peritonei, or PMP, is truly astonishing. Imagine a 3-liter bucket just filled to the brim with a complex, gelatinous, mucinous fluid. That is exactly what has to be removed during surgery for this condition. What happens is one of those mucinous appendiceal tumors ruptures, and it seeds the entire abdomen with tumor cells. Now, because these specific cells lack adhesion molecules, they don't clump or stick together. Instead, they just float freely in the normal peritoneal fluid, eventually implanting in gravity-dependent areas of the pelvis and abdomen. Over months or sometimes even years, they continuously churn out this jelly-like mucin, quite literally filling up the patient's entire abdominal cavity. Section 5, peritoneal inflammation, known clinically as peritonitis. So let's zoom out to the entire peritoneal cavity. This breakdown of peritonitis is an incredibly heavily tested concept, so pay close attention. We have primary peritonitis, which occurs without any sort of hole or gastrointestinal perforation. A prime example is spontaneous bacterial peritonitis, or SBP. We see this mostly in patients with advanced liver cirrhosis and ascites. SBP is usually a monomicrobial infection, very often just E. coli. Another primary cause is tuberculous peritonitis, which presents with ascites and, crucially, caseating granulomas on our biopsy. Conversely, we have secondary peritonitis. This happens when an organ actually blows out, like a perforated stomach ulcer or our gangrenous appendix from earlier. This literally spills a wildly polymicrobial mix of highly infectious gut bacteria directly into the sterile cavity. But it's really crucial to remember that peritonitis isn't always caused by a bacterial invasion. Sometimes highly irritating endogenous fluids just escape into the abdomen, and this causes a fiercely painful chemical peritonitis. We are talking about things like leaked bile, potent digestive pancreatic enzymes, or even blood pooling from a ruptured ectopic pregnancy or a hemorrhagic ovarian cyst. The peritoneum reacts violently to these chemical fluids. It causes extreme, agonizing pain, muscular guarding, and rebound tenderness, all before a single bacterium even enters the picture. And our final section, Section 6, Tumors and Fibrosis, Diseases of the Peritoneum. Let's talk about retroperitoneal fibrosis, or RPF. This is a really fascinating condition where a dense, inflammatory fibrotic scar tissue deposits deep in the abdomen, usually wrapping right around the abdominal aorta. In about 70% of cases, it's just idiopathic, an immune-mediated process we don't fully understand. But what makes this so incredibly dangerous clinically is that this constricting scar tissue can entrap and compress vital nearby structures. Specifically, it loves to strangle the ureters, which blocks urine flow and can very quickly lead to outright kidney failure. And finally, when it comes to actual tumors of the peritoneum itself, the landscape is pretty vast. We have primary malignant mesothelioma, which, just like in the pleural lining of the lungs, is heavily linked to asbestos exposure. There's primary peritoneal serous carcinoma, which histologically looks completely identical to ovarian cancer. Then there is a massive high-yield board favorite, the desmoplastic small round cell tumor, or DSRCT. This is an extremely aggressive sarcoma that usually pops up in kids and young adults. It's driven by a very specific chromosomal translocation, T1122, which fuses the EWS and WT1 genes together. You've got to know that one. But keep in mind, despite all these primary tumors, the vast majority of malignancies you'll actually find in the peritoneum are secondary metastatic implants from other organs, like the ovaries or the pancreas. And that brings us to the big picture we've painted today. It really leaves you wondering just how deeply interconnected our anatomy actually is.
I mean, think about it. A single tiny obstructed appendix or one isolated genetic gain-of-function mutation in a seemingly useless little organ can literally turn the entire massive abdominal cavity into a life-or-death medical battleground. The human body really is a masterclass in domino effects, isn't it? Keep studying these connections because understanding the why and the how behind these cascades is exactly what's going to make you an exceptional clinician. Thanks so much for joining me on this explainer, and I'll catch you on the next one.